Welcome to this Pro-CE podcast on expert discussion on the evolving treatment landscape in ovarian cancer, Pharmacist considerations for optimizing care. My name is Amy Ly Indorf. I'm a pharmacist at UW Medicine and Fred Hutch Cancer Center, and I'm joined by Dr. Sarah Hayward from OU Health.
Pleasure to be here.
Excellent.
Let's discuss.
So Sarah, just right off the bat, what PARP inhibitor are you seeing in the upfront maintenance setting?
Obviously with the FDA, with the indication and guideline indications, can use niraparib across the board for anybody, or caparib as well. But I think the physicians are just so much more experienced and comfortable with olaparib at my institution that's what we see the majority of. What about you?
We are seeing olaparib more so than the other two as well.
Yeah, absolutely. What are the decision-making factors that go into you guys deciding which PARP inhibitor you might want to use in that setting?
Yeah. Really looks at if their germline BRCA mutated, whether or not they're homologous repair deficient. And then those considerations to add it with bevacizumab really depend on what they received in their upfront adjuvant or neoadjuvant treatment. Did they get bevacizumab? If they didn't meet those requirements to get bevacizumab, then we wouldn't continue bevacizumab in that maintenance setting.
Absolutely. No, I think all those absolutely go into consideration, especially for access, making sure you follow guidelines and FDA indications. So we have to consider the patient's experience with that frontline chemotherapy. Some ACE they do great. They go through, they have no delays, they have no dose reductions. And those other patients, even in the frontline setting, for whatever reason, can struggle. For instance, if we've noticed a lot of struggles with, say, thrombocytopenia, we're a little bit leery of niraparib, just because we have seen those drops that you discussed where they're normal and all of a sudden they're less than 10,000, which is a very scary experience for everybody.
Yeah.
So taking that into consideration as well.
We haven't seen it quite yet, but I agree. If that patient's already struggling with hematologic toxicities up front and they're not germline BRCA mutated, rucaparib might be a good option based on the newest Athena mono data.
No, I agree.
What other common adverse effects are you seeing with PARP inhibitors?
Well, you really hit on a lot of them from a hematologic standpoint. We see more anemia with the olaparib. We see more thrombocytopenia with the niraparib. We haven't encountered any pneumonitis, which, knock on wood, we won't as well. We've had some patients that have encountered some of the cardiac issues we can see sometimes with niraparib, like a little bit elevated blood pressure. We've had patients with palpitations.
I think those unique side effects are really where we struggle a little bit more. We talk about all the hematologic toxicities and fatigue and nausea quite extensively in our upfront counseling, but haven't seen as much of that hypertension. We unfortunately have had a case of pneumonitis, but some of those other ones that are harder to characterize. So we've seen dyschezia months into therapy. And those are really hard for patients because it impacts their quality of life for years while they're on this medicine.
Yeah, absolutely.
Insomnia is a little bit more straightforward because you can just switch to morning administration. But just being aware of those unique adverse side effects and knowing that it's a possibility with these agents, it really helps patients feel confidence in our management and our team.
No, I agree. That's great. And I would just say across the board, probably the biggest thing we see regardless of product is fatigue.
Yeah.
And it's a big counseling point for patients that what's a reasonable expectation for fatigue, that we still want you to carry on with your life. We don't want you to feel miserable and stuck in bed for the next 2 to 3 years of your life. So, you have to let us know what's going to be tolerable for you. And so I think that's really, really a key point for patients. And, just letting them know that it gets better with time. They become accustomed to it. And I think they forget after a while for those patients that we have had complete their PARP inhibitor maintenance after the 2 to 3 years and they stop. They go, oh, wow. I think they're excited to be done, but also they get some of that pep back in their step.
Yep. Similarly, that's what we're seeing too. And it kind of dovetails into how we talk about adherence for patients in our first education session. Really, it's just keep in touch with us. Let us know what's going on, because even something like fatigue, there's lots of different things that can contribute to fatigue.
Absolutely.
And so I always ask them to let us be the detective to figure out what's going on, because anemia in those first 5 to 6 cycles can be a huge contributing factor. And so maybe we just need to address that.
Absolutely.
To make sure they can stay on the therapy without any adherence issues or self-titrating of medications.
Absolutely. And Amy, at your institution, just to make sure that everyone has access to the medications that are going to give them the best outcome, what do you all have in place to ensure that the uninsured or those that have high copays, what do you guys do for that patient population?
So we have a fantastic specialty pharmacy billing team, and they really look into all the options for a reasonable copay cost for our patients. So we do help enroll in the patient assistance programs that are available through the manufacturer. We do have some institutional charity care options, but really in my counseling, I always just say, you call the specialty pharmacy and they give you a copay that's out of your budget, let us know. Don't just give over your credit card information. Let us see if there are options for you, if we can try a different agent, anything like that. Because again, this is maintenance therapy for years. So financial toxicity is just as important as all the other toxicities we've talked about. What about you, Sarah?
I agree with all those. And we have that same setting in place. We do have a specialty pharmacy on site, which is really fantastic to work with. We have pharmacists whose job is to help us monitor and manage these patients who are on oral therapy, not only in our clinic, but across all of the disease sites here at our cancer center. But also having staff in place, we have technicians whose sole job is to help us with those prior auths, to help us with getting those patients signed up for those programs if necessary. Like you said, manufacturer copay, manufacturer free drug. We have an in-house grant program as well that patients can qualify for. And even there's private grants out there for specific disease sites if you can catch them when funds are available. But we always make sure that the patient is aware. I tell them, don't worry about it. We will help you out and we will make sure you get the medication that you need. So yes, don't pay that $3,000 copay. Most of them, I couldn't even if they wanted me to. So yeah, mirvetuximab. How many patients would you say you guys have going on mirvetuximab now?
Less than 10.
Okay.
Somewhere between 5 and 10. How about you?
Yeah, about the same.
Yeah.
It was really interesting when that came to market, all the testing that went into seeing if those patients had that folate receptor alpha. They actually ran out of reagent at some point in time and we had some delays. We're absolutely starting to see more of that. And we used it quite a bit here in clinical trials. So we have some familiarity here with our phase 1 program and late phase research. But I think the physicians are really excited to have it as an option in that platinum resistant setting. That's not something quite as cytotoxic as what we can see. And hopefully with some good outcomes for these patients who are in a bad way with their cancer.
There's a lot of excitement here too. And I think there's always drug updates as we make these presentations, but as that more confirmatory phase 3 data comes out, I think that excitement's going to grow. And one of the issues we've run into just in building those treatment plans, other than the testing that you've talked about, is that adjusted ideal body weight calculation, just educating everyone that it's a little bit different. And in particular, we, had a group discussion about what to do with patients who are low body weight. Maybe their actual weight is lower than their adjusted ideal. And so in our institution, we use their actual weight if it's lower than their adjusted ideal body weight. What are you all doing?
We're doing the exact same thing. This has only happened in 1 or 2 patients, but that's what we do. It makes sense logically for us. And so, yeah, if their actual is less than adjusted ideal, then we will go with their actual body weight. And we're getting ready to transition our electronic medical record, but the current one that we use for ordering actually doesn't calculate that for us. So we have to be very specific in our documentation about the weights that we're using. We spell out very clearly the math that got us to the number that we got to make sure that everybody is on the same page about what the dose needs to be so that we're following guidelines on that medication. When patients get to this setting and we talk about ocular toxicities, that's something that's, I guess, strange and new in the world of oncology medications overall. What is your approach to patient education and helping them go through the process of those exams and making sure they have their medication and making sure they know what they're supposed to do when?
That's usually the first thing the patients want to talk about because it is, they've gone through many lines of treatment. And so this eye care toxicity is like the newest one for them. And our patients are very savvy and they've done a lot of reading about this eye toxicity. And so things that we've done systematically are to build the eye care prescriptions into our treatment plans so that everyone gets the same instructions and gets those prescriptions. We have a supportive care medication calendar built out for them as well to really outline it. And that gets uploaded into the chart so people can see it.
Yeah, absolutely.
And then we've done a lot of education about it. How about you?
Yeah, absolutely. It's the same. And In the setting of gynecologic oncology, our first ADC that we really got to use to market was tisotumab in the cervical cancer setting. And so a little bit different in the eye care toxicity setting. And I think it's important to let everyone know, as we probably will see more antibody drug conjugates, they do not all have ocular toxicities. This is specific to the agent. So just as a by the way, ADC does not equal ocular toxicity. But the other thing is making sure your patient has access to some sort of eye care specialist or professional, making sure that they're aware it doesn't have to be an ophthalmologist, which sometimes are a little bit harder to get into than an optometrist. They can perform these same tasks, and making sure that eye care professional is exactly what you need so that you can get the information to treat the patient properly. And I agree that these are new toxicities for us and having to assess it, because we'll get the notes from our optometrist colleagues or ophthalmologists with a bunch of acronyms and things. I'm like, I don't know what that means. Is that a yes or a no? So I don't know if you've encountered that same thing, but you can actually find there's an ocular assessments guide on the manufacturer's website for eye care professionals to explain what we're after and why we're doing this, to sort of to streamline the process so that we're getting the information for what we need for patients.
Yes, the learning curve is high for these ocular toxicities for me. But it's been nice compared to some other ADCs where this one does open a wider field. It's been harder to get appointments with any healthcare provider, really. So being able to get one with an optometrist who can do a slit lamp eye exam. And I always encourage our patients just to book out appointments every 6 weeks times 4 so that, everything is set up and ready to go.
Yeah, I agree with you. And then just also knowing that there's different approaches to ocular toxicity. And I think also a big thing in patient education that maybe I wasn't so great at first is taking away demystifying the ocular toxicities for the patient, not making it sound so scary. It's just, if you follow this regimen with your drops, if you follow this regimen with your preservative-free eye drops, if you let us know as soon as things start to maybe seem weird, whether it's scratching or itching or redness or blurry vision, whatever the case, you're not going to go blind. And I think because that's the initial conclusion I feel like some of our patients jump to with this medication, which isn't true at all. What do you think?
That's great. I like that term, demystifying, because that is a lot of those, the questions all end up going towards will this be permanent? If something happens, will this be permanent? And the trial did show that most of it was reversible and that the risk for these are a lot less with the steroid regimen. And that's why the steroid regimen was developed. So I think just as a whole field, we're learning more about these ocular toxicities and ADCs and feeling a little bit more comfortable in using and discussing these with our patients in a less scary way.
Yes, I agree with that.
Well, Sarah, what do you see on the horizon for treatment in ovarian cancer?
Sure, lots of different things. Looking at things like, what if we give PARP maintenance twice? What about the addition of immunotherapy agents? We have the option, probably, depending on the data, to see another antibody drug conjugate come to treatment in ovarian cancer. We also have kind of a unique treatment option, TTF, it's tumor treatment fields, and which is really not drug related in that regard, except for, you would see this is looking at the Innovate trials that are using the TTF plus paclitaxel. So, I encourage everyone to read about the tumor treatment fields. There has been some studies done in glioblastoma. And so in the ovarian cancer setting, which we can always use more options in the ovarian cancer setting, especially in the recurrent setting, and especially in that platinum resistant setting. And so it's a low frequency sort of electric field that attacks rapidly dividing cells, or affects rapidly dividing cells is what I should say, and leaves those normal cells alone, which, when we think about traditional cytotoxic chemotherapy, that's not what it is. That's one of my first education points for patients. I'm like, these are chemotherapies that attack rapidly dividing cells. Your side effects are a lot because they don't know the difference between a normal and a cancerous rapidly dividing cell. So some of the TTF tumor treatment fields is to leave those normal cells alone. So that'll be some interesting outcomes to see from that.
It's amazing to see just new treatment modalities cropping up in this setting. We need them. Well, thank you, Sarah. I think this was just an awesome conversation to see what each of us do and experience. And it's nice to hear when it's the same and learn from each other.
Yes,
thank you
absolutely.
Thank you to the audience so much for listening today. We hope you enjoyed this podcast on the evolving treatment landscape in ovarian cancer. Please visit proce.com for additional information about ovarian cancer.
Thank you, Amy.